Hello, everyone. We are from SGDB6, studying in Emergency Medicine Block 2024, Udayana University Bachelor of Medicine. And in this video, we will present you a literature review titled Airway Management in Pediatric Patient. Before we continue, let us introduce ourselves. My name is SGD Basudewa Kanjaya. With last three digits of my student number is 139. You can see the rest of our SGD member on the screen.
Good morning, doctor. My name is Joseph Ngesiwe with the NIM 250. Today, I'll be describing the introduction of the airway management of pediatric patients. So, due to the pediatric patients, they possess anatomical features that are different from adults, such as tongue, nasal passage, and also the larynx. This causes the management to require modifications to accommodate the differences to ensure safety and efficacy of the pediatric patients. But the management will remain challenging due to age. Therefore, education, training, and research must be carried out to involve the management to increase the safety and efficacy for the patients. That's all from me. Thank you.
In this presentation, we will discuss about the anatomy and physiology of airways in pediatric patients, and then we will discuss about the indication, contraindication, equipment, techniques, complication, special consideration, and also the recent advancement in airway management in pediatric patients. Hopefully, this paper serves as a valuable resource for healthcare workers or healthcare providers, and together, we can improve patient outcomes and contributes to the medical field.
My name is Jinkar Susteja with the last digit name 080, and I'm going to explain about the anatomy of the pediatric airway. So there are several key differences, anatomically speaking, in the pediatric airway as compared to adults. First one is the narrowest part in children aged 5 and under. The cricoid cartilage is the narrowest part, and as for adults, it is the opening of the glottis. As for the shape, the larynx and the trachea in children are also more funnel shaped, and the larynx is positioned higher at the fourth cervical vertebrae, and the vocal cords are also more anteriorly slanted. As for the location of glottis, it varies upon depending on the developmental stages. For example, premature infants, it's at the third cervical vertebrae, and as for newborns, it's at the C3 to C4. So these anatomical differences will be vital in choosing the best airway management in pediatric population.
My name is Pandio Banimat Pratista, to related of my student number 201. I would like to present about the physiology pediatric airway. Infants have the higher oxygen consumption rate compared to adult, approximately 6 milliliter per kilogram per minute at rest. This coupled with a lower functional residual capacity makes them prone to rapid desaturation during the period of apnea. Additionally, pediatric patients exhibit increased CO2 production ranging from 100 until 150 to meet the higher metabolic demand. Children compensate with a higher respiratory rate than large tidal volume. The airway resistance, governed by Pessoa law, highlight the critical impact of even minor narrowing in the pediatric airway. Conditions like hemangioma, papilloma, and other can significantly compromise respiratory function. Managing this condition requires specific approach tailored to each disease, emphasizing minimal trauma to airway tissue to prevent the edema and future narrowing.
Swastiastu, Doctor and friends. My name is Fiona Aralia with the last three digits of my student number are 125. In this part, I'm going to explain about the indication of airway management in pediatric. Among the indications for airway management, the respiratory failure, which is often caused by hypoxemia or hypercapnia, might require immediate attention to stop the condition from worsening. Next is airway blockage. It can be caused by disease such as foreign body aspiration or infections such as croup or epiglottitis, and congenital abnormalities such as laryngomalacia or tracheomalacia. This requires immediate airway stabilization. Trauma is also another strong reason for pediatric airway control. face or neck injuries, as well as traumatic brain injuries, often harm the airway and require rapid evaluation and treatment to secure airway and prevent hypoxia. Furthermore, cardiac arrest and neurological deficits such as seizures and reduced consciousness are major scenarios in which airway management is needed to maintain patency and maintain respiratory function. Lastly, is during elective care such as surgery or diagnostic procedures. That is all from me. The presentation will be continued by my friend. Thank you.
Hello, let me introduce myself. My name is Jenny Sujaya. The last three digit of student number is 037. Now let me continue the presentations with 2.3 contraindications. So, minimal invasive maneuvers are preferred in pediatric airway management. Head-to chin lift maneuver is contraindicated if cervical spine injury is suspected. Obstruction found in the oral cavity can be cleared using a finger sweep or suction. However, blind finger sweeps are contraindicated in infants or young children due to its risk of pushing the material deeper. In pediatric patients, cricothyrotomy is rarely performed as emergency options. Most studies agree that the cutoff age for cricothyrotomy is no less than 8 years old. This is due to the smaller size of the cricothyroid membrane and the funnel-shaped larynx. Next, the laryngeal mask airway is usually used to provide effective ventilations and oxygenations. However, in infants or children with an intact gag reflex, LMAs are contraindicated. Nasal airway insertion is contraindicated in patients with serious centrofacial trauma due to its risk of intracranial tube migration. That's all for me. The next part will be explained by my friend. Thank you.
My name is Ariela Saharjo with last digit name 247. Now I will explain about the equipment used in airway management of pediatrics. Children are not miniature of adults. Due to several anatomical and physiological differences, selection of their airway devices need careful consideration. First airway management is back mask ventilation. A properly performed mask ventilation is the fundamental maneuver in airway management. Both in adults and children there are one and two hand techniques. For neonatal airway, one hand technique is usually effective. Next airway management is oropharyngeal airway. It maintains an open airway during induction of anesthesia and prevent patients from biting and occluding endotracheal tube. For the nasopharyngeal airway, they relieve airway obstruction by opening the nasopharynx. For advanced airway management, first that can be done is endotracheal tube. Cuff-ET tubes are preferable to decrease the air leak, pressure necrosis in ventilated patients, as the incidence of laryngospasm may be higher with uncuffed ET tubes in prolonged intubation. Second, supraglottic airway devices create a seal around the pharynx and act as a conduit for ventilation, oxygenation, and administration of anesthetic gas. Compared with the endotracheal tube, speed and ease of placement is higher in LMA. It avoids need of muscle relaxants and there is no hoarseness of voice. LMA is less invasive than ETT and preferred in children with upper respiratory tract infections. The choice of laryngoscopes depends on the age of the child and user preference. And for the last one, video-assisted laryngoscopy equipment is a more recent adjuvant in airway management that facilitates effective visualization of the airway. It has the potential to become the first-line option for intubation and for difficult airway, resulting in a higher success rate for intubations. I guess that's all from me. Thank you.
Hello, my name is Anak Agung Ayu Kirananda Darmautami, and the last three digits of my student number is 133. Today I'll be discussing about the techniques or treatment in airway management in pediatrics. The first is basic airway maneuvers. Now, one of the most important things, even if in using equipment, is the positioning of the patient. Head positioning is crucial with a neutral or slightly extended neck in older children and a sniffing position achieved with a towel roll under the shoulders in infants to maintain an open airway, as seen on the first picture at the top. They usually also use some sort of pillow or towel beneath the head to maintain the axis of the patient. Next is oropharyngeal and nasopharyngeal airways. These simple devices maintain the tongue in a forward position, improving airway patency. Side selection is vertical, and proper insertion technique is essential to avoid complications, which can be seen on the screen as well. The second image is an oropharyngeal airway, and the third is a nasopharyngeal airway. And then, besides the basic airway maneuvers, we can also give supplemental oxygen, such as face mask ventilation. Delivering high flow oxygen via a well fitting face mask is a cornerstone of initial airway management. It provides oxygenation and can sometimes alleviate upper airway obstruction. That is it from me. Thank you.
Hello, my name is Islam Bangdan with 102511103 as my store number. And for advanced airway techniques, there are two in particular, which is laryngoscopy and endotracheal intubation, and supraglottic airway devices. Laryngoscopy and endotracheal intubation is used for definitive airway control and mechanical ventilation, and this is used as the gold standard in clinical setting. There are some situations where it is required to use intubation. This includes low respiratory drive, uncertain airway patency, hypoxia, and hypercarbia. Things to consider while assessing signs within patients includes patient's mental state, potential airway compromises, awareness level, respiratory rate, respiratory acidosis, oxygenation level, and a Glasgow Coma Scale of 8 or less. These signs might indicate if a patient could benefit from using endotracheal intubation. However, within severe orofacial trauma, disruption of the facial or and upper airway anatomy are in the case of patients with spine injury or immobility. Intubations can be harmful due to cervical spine manipulation while using the intubation device. On the other hand, supraglottic airway devices are such as laryngeal mask airways can be provided for a temporary airway in specific scenarios. They offer an alternative to endotracheal intubation but may not be suitable for all situations. LMAs are used in attempting ventilation in a failed airway situation, followed by either intubation or while a surgical airway is performed. The other scenario being a temporary bridge to intubation by pre-hospital providers in cardiac arrest situations. However, LMAs can cause certain side effects such as coughing, aspiration, nausea, vomiting, and laryngospasm. Some contraindications of using LMAs include poor pulmonary compliance, high airway resistance, pharyngeal pathology, aspiration risk, and airway obstruction below the larynx. In the event that all the advanced airways techniques failed or in a more extreme scenario, surgical airway techniques such as needle cricotirotomy and surgical cricotirotomy or tracheostomy can be used instead. That is all from me. Thank you.
Let me introduce myself. My name is Anastasia Andretamerius and the last three-digit numbers are 154. Here I'm going to explain about the complications and challenges in airway management of pediatric patients. Anatomically, children have smaller airway and the position of larynx is more anterior and higher and has narrow glottic opening, which may cause the increasing incidence of obstruction. Psychologically, children have higher metabolic rate, which needs rapid management, and reduced residual functional capacity, which may cause hypoxia if not treated immediately. Psychologically, children are easily afraid, which increases the sympathetic tone, which may cause obstruction in airway management. Training and experiences are also needed in managing challenges that might come along the way during airway management, and the equipment needs to be standardized, redundancy, and safety with the correct size of equipments, which may be a challenge in several hospitals. Another complication or challenge is for presence of foreign bodies such as saliva, blood regurgitation, which may cause obstruction. Thank you.
Hello, doctors. My name is Nefi Nathaniel Sasanto. The last three digits of my student number is 051. Now I'm going to explain the special considerations in airway management in pediatric patients. Pediatric patients aren't very commonly found in airway management. A study from 2017 found that pediatric patients constitute 7 to 13% of all patients requiring emergency medical services. Although children only make up a small fraction of patients, it is important for a paramedic or attending physician to understand the certain considerations when securing the airway of a pediatric patient. Pediatric airway management comes with its own set of challenges. As mentioned before, pediatric airways differ especially in their anatomical and physiological aspect. The patient should should be laid supine with a towel placed under the shoulders. The purpose is to counter the flexion of the neck, where there is usually a natural flexion in children when placed supine due to the large size of their head. This natural flexion is important because it can create a potential airway obstruction. This position also helps to align the ear canal to the sternal notch to help when physicians need to give ventilation using a back valve mask. The tongue also poses a high risk towards airway obstruction. In children, their tongue is proportionally larger than in the oropharynx. Thus, the insertion of an oral or nasal airway can prove to be helpful in situations like this. It is also important to note that some pediatric patients don't have fully grown teeth, which can cause some difficulty in ensuring a good mask seal because of a lack of platform for the mask to rest on. The amount of air given should also be monitored closely because excessive pressures may cause barotrauma in pediatric patients, and there's also risk of hyperventilation. In certain cases, when there is more advanced airway techniques that are required, it is important to check for pediatric sizes for the device. If possible, avoid the use of invasive devices unless basic maneuvers have been attempted beforehand and prove to be of no help. Inexperience in managing pediatric patients also play a role in increased difficulty of securing airway. It is important to keep up with the latest research and studies regarding pediatric airway management to make sure that the methods being used are relevant and up to date. Simulations and trainings done from time to time may be helpful to increase proficiency in managing pediatric cases. Maybe that is all that I can talk about regarding the special considerations of the pediatrics in airway management. That is all for me. The next will be continued by my friend. Thank you.
Hello, my name is Putu Adisti Sisla Sujana with my three last digit of student number is 241. I will be continuing the explanation about the recent advancement in airway management in pediatric patients. So there's a device, the first one is supraglottic airway devices, which have improvement in models, provide better seal, and are easier to insert, reducing the risk of airway trauma. The next one is video laryngoscopy. This device offers better visualization of the airway, beneficial in difficult airway cases. It shows a significant reduction in the incidence of severe complications and improve first attempt success of intubation rather than direct laryngoscopy. The next device is cuffed endotracheal tubes, improvement in design which minimize the risk of airway injury while providing a better seal. The next one is a high flow nasal cannula therapy. This device delivers heated and humidified oxygen at high flow rates, which have advancement are centered on optimizing ventilator settings and customizing monitoring to prevent any complications. And the last one is flexible bronchoscopes. Advances in flexible bronchoscope have improved the ability to manage complex airway cases in children. They allow for a better visualization and management in airway obstructions due to its flexibility. That is all from me. Thank you.
Hello, my name is Amanda Devasha and my last three digits of student number is 068. Now I will explain about the conclusion. Airway management in pediatric patient is a critical component of emergency and anesthetic care. Airway management in pediatric patient is to make sure a safe and controlled environment during elective care such as surgery or diagnostic procedures. There are several key anatomical differences in managing airway emergency in pediatric population. In pediatric patients need special attention to their airways because of their unique anatomical and physiological features. Minimally invasive maneuver are preferred in pediatric airway management. The head tilt chin lift maneuver may be performed unless cervical spine injury is suspect, in which case a jaw thrust maneuver should be performed instead. Managing airway in pediatric patients comes with its various challenges and complications. It is important to keep up with the latest research and studies regarding pediatric airway management to make sure that the methods being used are relevant and up to date. Stimulation and trainings done from time to time may be helpful to increase proficiency in managing pediatric cases. That's all from SGD B6. Thank you.